This week, my topic is pulmonary embolism. So, pulmonary embolism, or PE, is a life-threatening cardiovascular emergency that's caused by the obstruction of a pulmonary artery by an embolus. Now, most often, a thrombus is originating from a DVT or a deep vein thrombosis in the lower extremities. Less frequently, though, a PE can result from embolization of air, fat, or tumor cells. Together, PE and DVT constitute venous thromboembolism, or VTE, a condition that poses a significant burden to healthcare systems worldwide, affecting more than 100,000 individuals annually in the United States and contributing to substantial morbidity and mortality. The development of PE is primarily explained by Burko's triad, which consists of venous stasis, endothelial injury, and hypercoagulability. Venous stasis results from prolonged immobility, such as hospitalizations, long-haul travel, or obesity, which reduces venous blood flow and increases clot formation. Endothelial injury, often caused by surgery, trauma, or central venous catheterization, leads to platelet activation and thrombogenesis. Hypercoagulability may be inherited or acquired, such as in instances like malignancy, pregnancy, or oral contraceptive use, which also increases the risk for thrombus formation. Once a thrombus dislodges, it travels through the venous system into the right atrium, right ventricle, and pulmonary arteries, where it obstructs blood flow and oxygen exchange. The consequences depend on the embolus size and location. Small emboli may be asymptomatic or cause mild dyspnea, pleuritic chest pain, or tachycardia, whereas moderate-sized emboli result in hypoxia, hemoptysis, and tachypnea due to ventilation, perfusion mismatched, and pulmonary infarction. Massive PEs, which is occlusion of greater than 60% of pulmonary circulation, can lead to acute right ventricular failure, decreased cardiac output, systemic hypotension, and cardiac shock, which those can be fatal if left untreated. So, as mentioned earlier, majority, about 90% of PEs originate from DVTs in lower extremities, where blood flow stagnation increases the likelihood of clot formation and embolization to the lungs, which is why in the hospital we often use sequential compression devices to get that blood flow moving in the legs. Several risk factors contribute to this process. Prolonged immobility, such as bed rest or long flights, which slows venous blood flow, promoting clot formation due to a lack of muscular contraction in the legs. Also, recent orthopedic surgeries increase clotting risk due to vascular injury, inflammation, and prolonged immobilization post-surgery. Malignancies, such as pancreatic, lung, hematologic, and gastric cancers, create prothrombic states by stimulating production of clot-promoting factors, making thrombus formation more likely. Pregnancy increases blood volume and places pressure in the inferior vena cava, reducing venous return and increasing the risk of clot formation. Obesity contributes by compressing blood vessels and increasing inflammatory markers that promote coagulation. Smoking damages the endothelium of blood vessels, triggering an inflammatory response that increases clot formation. Oral contraceptive use, especially those that contain estrogen, increase clotting factor production and decrease natural anticoagulants, predisposing individuals to thrombus development. And lastly, there are genetic predispositions such as factor V, hyperhomocythemia, and protein C or S deficiency, which all of those impair normal anticoagulation mechanisms and make blood more prone to clotting, which increases the PE risk. PE presents with a wide range of clinical symptoms depending on the extent and how large the thrombus is and how much of the pulmonary artery is occluded. The severity of symptoms varies from mild dyspnea to life-threatening cardiovascular collapse, as PE disrupts normal gas exchange and pulmonary circulation. So, Dyspnea or shortness of breath. This occurs due to ventilation perfusion mismatch as blocked pulmonary arteries prevent efficient gas exchange and leads to hypoxia. Pleuritic chest pain is caused by inflammation of the pleura due to embolism-induced ischemia in the lung tissue, which stimulates pain receptors in the pleural lining. A cough can result from irritation of the airways due to the pulmonary infarction or inflammatory cytokine release, which leads to increased bronchial secretions. Some moderate PE symptoms include sudden dyspnea, as a larger embolus can block more pulmonary circulation, which further impairs oxygenation and triggers increased respiratory efforts to try to compensate. Tachypnea or increased respiratory rate. The hypoxic state can stimulate chemoreceptors in the brainstem, increasing the respiratory rate to compensate and improve oxygen delivery. Tachycardia. The SNS activation is activated in response to hypoxia and decreased cardiac output, which can increase the heart rate to try to maintain that perfusion. Hemoptysis or coughing up blood. This can occur due to pulmonary infarction, where damaged lung tissue undergoes necrosis and can lead to a rupture of pulmonary vessels and alveolar hemorrhage. Now, a severe PE can often look like severe chest pain from acute right ventricular strain and the ischemia pain from the sudden increase in pulmonary vascular resistance and inability to pump the blood effectively. Hypotension, as a large emboli obstructs blood flow to the lungs, reducing left ventricular preload and ultimately leading to decreased cardiac output and systemic hypotension. Syncope or losing consciousness from cerebral hypoperfusion. As the heart struggles to maintain adequate circulation, it's going to lead to temporarily loss of consciousness. Or cardiovascular collapse, shock from acute right heart failure, where the right ventricle cannot pump against the high pulmonary pressure, and it leads to reduced cardiac output, tissue hypoxia, and multi-organ failure. So here is a patient with all of the signs and symptoms. Now, because PE symptoms can overlap with other cardiopulmonary conditions, diagnostic confirmation relies on clinical probability scoring, lab tests, and imaging. The Wells criteria, as well as the Geneva score, help stratify patients based on pretest probability of PE. D-dimer testing, a marker of fibrin degradation, has high sensitivity but low specificity. A negative D-dimer, less than 500, effectively rules out PE in a low-risk patient, while elevated D-dimer over 500 necessitates the need for further imaging and workup. CTPA is the gold standard for diagnosing PE, offering direct visualization of thrombi in the pulmonary arteries. Ventilation perfusion or VQ scanning is also an alternative if CTPA is contradicted due to renal impairment or an allergy to contrast. An ECG may show sinus tachycardia or right heart strain, and a chest x-ray can include Hampton's hump, which is a wedge-shaped infarction, and Westmark's sign, though these have low sensitivities.